Ishita, you can start.
Very good evening, one and all. Warm welcome to this ISA National Online PG class. These classes held on every Monday at 6:30 p.m. I welcome all the esteemed faculty. Our senior consultant, and all the postgraduate students. Myself, Dr. Ishita Agarwal. I recently completed my post graduation from Jamnagar, Gujarat, and I'll be one of the screen coordinators for today's session. So today's session topic will be anesthesia for non-neurological surgeries in neurological patients. So before we commence our session further, I would like to begin with seekings of the blessings of Lordess Saraswati with Saraswati Vandana. So I may now request our Honorary Secretary Dr. Sukhminder Bajwa sir to address the audience.
Thank you, Dr. Ishita. Today, I think the group of classes today is a very, very important topic, and that non-neurological surgery, neurological problems. These are the most challenging surgeries, actually. You bring any neurological patient for a neurosurgery, we are very much prepared. The prognosis is well explained, and the recovery parameters also well explained to the patient. But in such patients where patients coming for non-neurological surgery with neurological problems, things can go awry at any time, and that's a very challenging task. As anesthesiology has advanced, so has its branches now, the subspecialty and super specialties. With neuroanesthesia, the patient safety profile has increased. The prognosis has also, improved over the years. The way the neuroanesthesia is progressing in our nation, I think we are getting more and more good results from the neurosurgery. Previously, I think if you go 2 decades back, even the surgeons, after doing MS surgery, they were very reluctant to take up the neurosurgeries as a specialty, super specialty. But now, with so many advancements, even in the neuronavigation and so many other techniques have also come, and with I think I owe it to the development of neuroanesthesia, that the neurosurgeries have become more safer, more result oriented, and a better recovery in these patients. So we will like to hear all these things from our very a good team, a mix of good team with led by Dr. Punay Vanamurthy. So I hand it back to Ishita to take it further.
Thank you, sir, for your words. Now I would like to call upon my co-screen coordinator, Dr. Rakhi, to take over the session further. Over to you, Dr. Rakhi.
Thank you, Dr. Ishita. Good evening, one and all. A very warm welcome. I myself, Dr. Rakhi Mohan, currently working as registrar at SP Medifoot Hospital, Trivandrum, Kerala. It's indeed an honor to be one of your coordinators for today. I would like to extend my warm welcome to our distinguished faculties for the day. Now, without any further ado, let me introduce the esteemed key faculty and the speakers who lead this session. Please join me in welcoming them. One second, sir. Okay, now to start with, Dr. Punaya sir. Dr. Punaya Vanamurthy. Sir is a HOD and Senior Consultant, Kaveri Hospital, Chennai. Sir is a Program Director, Fellowship in Neuroanesthesiology and Critical Care. Specialty interest, Neuroanesthesia. Achievements. He was a past secretary, Indian Society of Neuroanesthesia, Critical Care. And Sir is also the past president, Neurocritical Care Society of India. Sir has been awarded the Neurocritical Care Society USA Presidential Citation 2019. National, and he has so many national and international presentations, publications to his side. We welcome you, sir.
Thank you.
Now let's welcome our faculty presenter for the day. Next one is Dr. Sindhupriya M. Dr. Sindhupriya M. Ma'am. She's a consultant at Kaveri Hospital, Chennai. Ma'am is a teacher, fellowship in neuroanesthesiology and critical care. Ma'am's specialty interest is neuroanesthesia as well as intra-op neurophysiological monitoring and point of care ultrasound, neurocritical care, trauma and stroke. Ma'am has been awarded the Times Health Excellence Award, and Ma'am has also received the Neurocritical Care Society of India Presidential Citation 2023, 2024, 2025. And she has many national and international publications to her side. We welcome you, ma'am.
Thank you, Dr. Raki.
Thank you, ma'am. Our next faculty presenter is Dr. Madanki Krishnakumar, ma'am. So, Dr. Madanki Krishnakumar, ma'am is an associate professor at St. John's Medical College Hospital. She has a total PG teaching experience of 8 years. Her specialty interest is neuroanesthesia and neurocritical care. She is a gold medalist during her DM period, and she is a ISA Yuva Young Anesthesiologist of the year 2019. And she has presented in 20 plus conferences. And ma'am is also a holder of the Fugate Fellowship. Now let's know what is a Fugate Fellowship. Fugate Fellowship is a global health and research training program which is supported by the Fugate International Center, US. Ma'am is also awarded the Shekhar Dhanvijay Award 2025, and also she has received the NCSI Presidential Award 2023, 2024 and 2025, and she has 45 publications to her name. We also welcome you, ma'am.
Thank you. Thank you for that kind introduction.
Thank you, ma'am. Our next presenter for today is Dr. Anand Chakravarti. Sir is a consultant anesthesiologist at Kim Sunshine Hospital, Hyderabad. Sir's specialty and interest is neuroanesthesia. We welcome you, sir.
Thank you, Dr. Raki.
Okay, now it's for the PGs who has joined as audiences in this session. To ensure smooth, productive, and respectful learning environment for everyone, we have to follow but few important guidelines. We ask all the participants to follow. We request everyone to keep your microphones muted throughout the main lecture to prevent any background noise interference. And audience are supposed to keep their videos off. They can type their queries in the chat box, which will be cleared by the consultants after the class. With that, let's dive into the session. Over to you, Punaya, sir.
Thank you. Thank you so much for the kind introduction. First of all, I'd like to
Thanks.
thank the ISA for providing us this opportunity for this lecture. Thank you, Honorary Secretary ISA and Madhuri Madam for their active enthusiasm and taking this subject. Surgery for neurological patients, non-neurological surgeries for neurological patients. So this is a very unique topic in the sense most of the times when we do PAC, when we handle patients for anesthesia, we concentrate more on the cardiovascular aspects, the systemic illness, respiratory illness. But these kind of patients do present for surgeries, and we are limited by data, that we don't have much robust data on managing such cases. But when we get such patients, we need to have a systematic approach on how we approach this patient in the pre-anesthetic checkup, carefully stratifying the risk for perioperative management, and how to manage these patients intraoperatively. There comes the challenges with, like Sir said, of the latest advancement in neuroanesthesia and the neurosurgeries. There are a lot of things which are happening, and many patients who are deemed unfit for some neurological procedures are getting procedures done, and newer procedures are coming each and every day, including procedures like deep brain stimulation for Parkinson's disease, and even elderly patients are subjected to neurological surgeries. And there are also neurological conditions which can happen in the perioperative period as an unexpected complication, including perioperative stroke, post-operative intracerebral hemorrhage, post-operative seizures. So all these things can happen. So we also will cover up the post-operative aspects of such patients. So to start the session, I'll be first inviting my first faculty, Dr. Sindhu Priya, to present her presentation on anesthetic management of patient with deep brain stimulation coming for a non-neurological surgery. Dr. Sindhu Priya, just can you take us through the perioperative management of such a patient who has a DBS, an implant in situ, which is like a pacemaker for the brain, and how to evaluate the patient, how to manage the intraoperative anesthesia technique, and the glimpses on postoperative management as well. Over to you, Dr. Sindhu.
Thank you, sir. I would like to thank the organizing committee for giving me this opportunity on this esteemed platform to present my talk. So I would be discussing about the anesthetic management of a patient with DBS stimulated in situ coming for a surgery. So the traditional indication for a deep brain stimulation is Parkinson's disease, but its use is just not limited only to Parkinson's, but it's also used for other disorders like central tremors, and then restless leg syndrome, or psychiatric disorders like severe depression and obsessive compulsive disorders, metabolic disorders like severe obesity, and refractory epilepsy as well. So we need to understand the components of the deep brain stimulation system. Here, a set of electrodes are inserted into the target nucleus in the brain, and there is a pulse generator which is implanted into a pocket which is made below the clavicle for the patient. And these two structures are then connected via an extension wire which is tunneled into the neck. Since the most common indication of DBS is Parkinson's disease, let's just go through the systemic effects. So Parkinson's can cause dysautonomia, it can cause sleep disorders, neuropsychiatric manifestations, cognitive impairments, sensory symptoms, fatigue, and weight changes resulting in anorexia and low protein levels. So our role may be seen when a Parkinson's patient with a DBS comes for an MRI, or when the DBS patients come for a battery replacement, or if they come for any other surgery, or maybe even an electroconvulsive therapy. So what are the anesthetic implications of Parkinson's disease? It's very important to understand. We have to remember that the respiratory complications are the main reason for mortality and morbidity in these patients. This is mainly because they have incoordination between their pharyngeal and the laryngeal muscles, and this causes pooling of the saliva, and which can get easily aspirated, resulting in a aspiration pneumonitis. They can also have obstructive component as well as restrictive component. Cardiovascular system wise, they can have orthostatic hypotension, mainly because of or orthostatic hypotension because of the autonomic dysfunction. They're also very prone for having arrhythmias, and it becomes worsened because of the medications they take for the Parkinson's. They can also be hypertension because of the autonomic dysfunction. They can also have gut problems like delayed gastric emptying, so we have to adhere to the NPO orders. And excessive movement or bradykinesia can be there because of the Parkinson's, which can result in challenge for positioning the patient on the table, and also it can cause artifacts on the monitoring. Neuropsychiatric manifestations, because they can have mood disorders and dementia. So this makes it very difficult to elicit a very good pre-anesthetic history from the patient. So we need to rely on the bystanders as well as the medical records. And drug interactions and sensitivities we'll be discussing. So these are the drugs which are used. Even though the patient is having a deep brain stimulator, the patients will be on medications for the Parkinson's as well. So in case the patient is on levodopa, we have to continue the levodopa in the perioperative period until surgery. Its duration of action is around 1 to 2 hours. And we have to resume the levodopa as soon as possible after the surgery. And if the so dopaminergic agonists like pramipexole and ropinirole also need to be continued in the perioperative period. MAO-B inhibitors like selegiline and rasagiline, some anesthetists choose to discontinue it mainly because of its interaction with the opioids. But if we know which opioid we're going to use, suppose say we're going to use morphine, we can continue the MAO-B inhibitors safely. COMT inhibitors like entacapone and amantadine are generally continued in the perioperative period, and anticholinergic drugs are generally discontinued, especially in the elderly patients, due to an increase in the confusion risk. So the perioperative journey is a 3-stage approach, which comprises of the preoperative assessment, intraoperative management, and the postoperative vigilance. In the preoperative period, it is very essential to assess the cognitive baseline. In fact, in our institute, we always have the psychologist to do a cognitive assessment for the patient, psychological assessment. We have to evaluate the autonomic function. We have to check for dysphagia and the aspiration risk. It's a good practice to see for any pneumonia like patches on the chest X-ray. And the chest X-ray is also very important to see which side is the pulse generator located. Is it on the right side below the clavicle or on the left side? We have to confirm the medication schedule, what medications the patients are taking, and if the DBS is switched off, how bad are the off symptoms? Off symptoms means how severe are the Parkinson's symptoms when the patient's DBS is switched off. And we have to, very important to note is, we have to note the details about the deep brain stimulator device, that is when it was placed, for what indication it was placed, when was the battery changed at last, what is the battery life. We have to consult our in-house neurologist and keep him or her in the loop. And we also have to get the communication details of the DBS technologist, so that they can come and help us to switch on and off the device. So intraoperatively, we have to follow the ERAS protocols. There is no particular ERAS protocol for the Parkinson's. The general ERAS protocol rules apply here as well. We should choose GA versus regional carefully according to the surgery. We have to avoid the contraindicated drugs, which we will be discussing. We can use invasive monitoring when it is required. We have to monitor the temperature very closely, because these patients have autonomic dysregulation and they are prone for hypothermia. So the OT temperature has to be kept in a comfortable range. And very important is, we have to manage the electromagnetic interactions which is associated with the DBS device. So this is an ECG of a patients with actually just tremors, but we might think of it as a ventricular tachycardia. So we should not go to treat the ECG. We should actually treat the patient. And this is an example of the monitor which is showing ECG artifacts because of the tremors which the patient is having. It is not any other ECG abnormality. And we can also see the SpO2 probe is also having a lot of artifacts. So these are very, very commonly seen, especially when you do the case under regional anesthesia. So coming to the drug interactions, opioids like pethidine, fentanyl, and tramadol, we have to be careful with it. Pethidine, post-operative shivering is a very common complication. When we use pethidine very commonly for that, but in a patient who has been taking rasagiline and selegiline, we have to be very careful, because giving pethidine can cause serotonergic syndrome, which can manifest as hyperthermia, fever, and muscle rigidity. Fentanyl can cause muscle rigidity even in normal patients, but there is high risk in patients with Parkinson's. We have to be aware of it and tackle it when it happens. Antiemetics, like as a prophylaxis, it's we usually use ondansetron, but the other options are metoclopramide, but we should not use it because it is a D2 receptor blocker and it can worsen the Parkinson's symptoms. And suppose the patient is having a post-operative delirium. Haloperidol that is Serenus is a very excellent choice, but we cannot give it because it worsens the Parkinson's disease. So we have to use atypical antipsychotics instead of that. And inhaled anesthetic agents like halothane can trigger the arrhythmogenic potential of the patient and can cause cardiac arrhythmias. So the safer alternatives are sevoflurane and isoflurane. And IV anesthetics like thiopentone can also worsen the Parkinson's. So the safer bet would be propofol. So coming to the electromagnetic interference, it is very important to use bipolar cautery over here because the electric current would just travel between the two tips of the bipolar cautery. Whereas in the monopolar cautery, if you see, the current travels between the tip and the return plate, which is usually placed under the thigh or under the calf muscles of the patient. So here you can see, so that is the pacemaker, and here is a monopolar cautery. So from the monopolar cautery, the current will pass through instead of the pulse generator and then to the return plate, and then again it will go to the monopolar cautery. So it will form a continuous circuit, making the patient itself a circuit basically. This is another diagram which shows the same thing. So that is a monopolar cautery. From here, the current will go into the diathermy unit and then it will go into the ground plate. So if we have our pulse generator on the left and you place this ground plating also on the left, then the current is going to pass through the entire thing in a vicious cycle, and the patient himself becomes an electric circuit, which becomes very dangerous. And in the bipolar cautery, from one tip, the current passes from one tip, it goes into the diathermy and it gets passed into the other tip. So it makes it very safe for the patient. So why are we worried about this electromagnetic interference? Because the concern is that it can cause thermal injury to the brain. It can cause damage to the DBS device itself. It can reprogram the previous, whatever program was set into it. And it can also cause shock to the patient. So the primary recommendation is a bipolar electrocautery, and strongly strongly monopolar has to be avoided. And the patients have described the monopolar when the monopolar cautery has been used, they have described it as a lancinating electric shock-like sensation, whereas they were very comfortable when the bipolar cautery has been used. And if the monopolar cautery is being used, then the ground pad positioning is very, very critical. We have to position the ground plate so that the current pathway does not pass through it, or the DBS pulse generator or the leads. For a head and neck procedure, the grounding pad can be placed on the superior posterior aspect of the shoulder, which is contralateral to where the pulse generator is kept. So this is where the X-ray is very important, where you can know the position where the pulse generator is kept. The goal is to create a current path that avoids the entire DBS system. And even if you're using a bipolar, we have to use absolute minimum power settings, which is necessary for the hemostasis. Apply only short and intermittent and irregular bursts rather than a continuous activation, and maintain a maximum possible distance between the catheter tip and the pulse generator, and avoid proximity of the cautery's electrical field to any component of the DBS system. And we can consider, and if the surgeon can consider alternative hemostasis methods like a harmonic scalpel, it has no electric current, so therefore there will be no electromagnetic interference. Or if there is a battery operated heat generating handheld electrocautery that has got very minimal electromagnetic interference and it has been used successfully in DBS patients. So if in case the patient has come as an emergency case and we're not able to turn the DBS off, then the patient becomes highly dependent on the continuous DBS therapy, as turning it off is not feasible. So here, bipolar cautery becomes absolutely mandatory, and we have to optimize the ground padding positioning even more carefully. It becomes very important. So the ground padding and the pulse generator should not be on the same limb. And if it's an elective case, then it's better to postpone it until the device management can be optimized. So now, whether it's going to be GA versus regional anesthesia, we need to know the pros and cons of both. So in general anesthesia, it masks the tremors, it provides the stillness for surgery, but the disadvantage is that it can mask the neurological symptoms. There is a higher risk of vomiting, increased post-operative delirium and drug interactions because of the polypharmacy involved. But the drug which is preferred if GA is given is propofol because of its rapid metabolism, the antiemetic properties, and tremor suppressing properties. although even this has a slight incidence of dyskinesia, especially at the time of emergence. We have to avoid halothane. Again, as previously discussed, it can cause cardiac sensitization. And thiopentone can worsen the Parkinson's, and ketamine can add on to the autonomic dysfunction. If it is regional anesthesia, the advantages being immediately after the surgery, the patient can start taking the medications. There are lower risk of respiratory and urinary complications, and neurological monitoring can be done in a real-time basis. But the disadvantage is that the patient will continue to have tremors and dyskinesia. It will interfere with our monitoring also, and maybe even for the surgeon to operate, and even positioning the patient becomes extremely challenging. So local anesthetics are generally safe, but if you're going to use adrenaline-containing local anesthetics in a patient who's on COMT inhibitors, especially entacapone, they may have hypertensive episodes. So you need to keep that in mind. So in the post-operative management, immediately at the time of reversal or before the reversal, the DBS machine should be switched back on. And we have to reinterrogate the device to ensure that it's functioning properly, and we have to verify that the settings have not changed. So for this, it's better if the technologist has been informed prior and he's available to do the same in the recovery room. And we have to document any changes, if any, in the device parameters. We have to see for any complications like signs of electrode heating injury, which may manifest as elevated pacing or sensing thresholds in the days following the surgery. Device malfunction, including reprogramming, inhibition, or the noise reversion mode also needs to be monitored. And we have to also see if the patient has developed any neurological symptoms, which could indicate any brain tissue damage because of the electrode heating. So before the reversal itself, the DBS machine should be switched on. We have to, and in the post-operative period, the Parkinson's medications should be started as soon as possible. If the patient is drowsy or cannot take orally, then an nasogastric tube has to be inserted and the medications have to be given promptly. Or if the surgery is, or if it is a gastrointestinal surgery and it precludes an enteral nutrition at all, then we have to discuss with the surgeon preoperatively itself, and subcutaneous apomorphine infusion should be instituted. So that has to be decided in the preoperative period itself. And we have to prevent and manage the delirium. We have to optimize the pain control, address the respiratory complications, and manage any hemodynamic instability, if any. In the postoperative period, we have to be vigilant for the Parkinsonism, hyperpyrexia syndrome, delayed recovery, any respiratory complications like aspiration pneumonia, severe hypotension, and postoperative delirium. Parkinson hyperpyrexia syndrome is also known as a neurolip malignant-like syndrome, or the dopaminergic malignant syndrome. This is mainly because of the severe hypodopaminergic state, which results because of the reduction in the levels or the withdrawal of the dopaminergic medications. So the treatment is, first is identification, and we have to restart the dopamine therapy, dopaminergic therapy as soon as possible, and supporting measures. Failing to do that would result in a mortality ranging from 4 to 30%. So managing postoperative delirium, as we know, most of the patients are elderly patients with Parkinson's. They are very prone for developing postoperative delirium. And though haloperidol is an excellent drug for other patients, we cannot use it for managing a delirium in Parkinson's. We have to use atypical antipsychotics like quetiapine. So can a DBS patient undergo MRI? The main hazard over here, the main caution over here is the electromagnetic interference. And also, even if we place an aneurysm clip in a patient, it can cause artifacts. So here we have an electrode as well as a pulse generator. This can cause artifacts. It can cause heating of the DBS system. It can also cause its dislodgement. And the heating and the heat generated, it depends on the characteristic of the stimulator and the area of interest which is being imaged. Is it far away from the pulse generator, the strength of the magnetic field, and the coil? As a first step, we have to always switch off the DBS, and we have to use a weaker magnetic field MRI, like a 1.5 Tesla MRI instead of a 3T Tesla MRI. And we have to use only this, we have to do the MRI for a shorter duration of time. So do only the most important sequences. And we have to switch on the DBS after the procedure and check the device and its functioning. So what about patients who need electroconvulsive therapy? So again, over here, electromagnetic interference is a concern. So it can cause a heating of the DBS system and can also cause the dislodgement. As a first step, we have to switch off the DBS. And the case reports, they have used the lowest possible current, and they have to place the electrodes far away from the pulse generator, and the ECTs have been done safely. Thank you.
Thank you, Dr. Sindhu, for that wonderful presentation and taking us through the perioperative management of patient who has got a deep brain stimulator and they have to undergo non-neurological surgery. We'll come to the discussion and discussion about the questions posted by the PG at the last. Before that, I will invite Dr. Matanki to present the anesthetic management for non-neurological surgery in a patient who had a traumatic brain injury. It's very important because it's not only the surgery and perioperative management, it's also about the overall prognosis of the patient. And as anesthesiologists, the way we manage these cases intraoperatively greatly influences the overall outcome of the patients. Over to you, Dr. Matangi. Can you just take us through the step-by-step approach of the perioperative management from the preoperative, intraoperative, and postoperative management of such patients presenting for non-neurological surgery?
Thank you, sir. I would like to thank the organizer for this opportunity. So when we look at traumatic brain injury, so what are we actually looking at? So first, traumatic brain injury comes in different sizes and forms. So it can be from a depressed skull fracture to a subdural hemorrhage, extradural hemorrhage, and a contusion. And also these patients can have contaminant extracranial injuries when they come up for surgery. So in this condition, what do we do? So how do we approach a patient like this? So the objective of this presentation is to understand the concept of brain protection and secondary brain injury and prevention, and also the principles which will guide our anesthetic management. So what is most important is at the point of primary brain injury, where the TBI occurs, there is not much of brain protection which can provide. But what we can do as anesthesiologists in the perioperative period is to try to reduce the amount of perioperative secondary brain injury. So whenever a trauma occurs, there are processes in the brain, there is excitotoxicity, ischemia, apoptosis, and neuroinflammation happens, which causes worse prognosis and causes more brain damage. So in an event when extracranial trauma or anything the patient undergoes, even a general anesthesia is considered an extra insult to the brain. So all of this further makes the secondary brain injury worse. So this is what we as perioperative physician can actually prevent or treat. So the hypothesis is whenever there is an extracranial surgery or general anesthesia, this neuroinflammation is much more, and studies have found that this can make neurocognitive decline much worse, and the outcome can be worse. So if we look at traumatic brain injury per se, in more than 70% of severe TBIs, they also have more than one extracranial injury. And this determines the mortality and the prognosis in patients with TBI. So as we all know, TBI can be classified as mild, moderate, severe based on the presenting GCS, and mortality significantly increases when systemic injuries coexist. So what do we do when a patient has multiple trauma? Main aim here is to first stabilize the patient and then investigate. So always consider stability of the patient before proceeding further. And in the era of POCUS, there gives an opportunity to simultaneously look for other injuries which directly or indirectly have an effect on the brain. So when a patient with severe trauma comes with polytrauma in the first 24 hours and hemorrhage is the main concern, first thing is life-threatening things have to be controlled, which the principles of trauma management has to be considered, where we intervene for bleeding control and focus on maintaining the blood pressure. And simultaneously, we should also consider the effect of this on the brain. So at that point, if the brain injury is the pressing thing, patient might go in for emergency neurosurgery. If there is no emergency neurosurgery for the brain, with brain protective strategies, we need to proceed in surgeries for the extracranial injuries. So here, what the primary survey is important, followed by secondary survey, and then we proceed with brain and organ protective strategy. So let's look stepwise what we need to do. So each injury has an effect on the brain. For example, thoracic injury, when it happens, there is obviously hypoxia and hypercarbia, which can worsen your intracranial pressure. So your ventilatory strategy should focus both on protecting the lung and also protecting the brain. So we cannot use very high PEEP when there is also a brain injury. When we look at abdominal trauma, though damage control laparotomy is what is favored if hemodynamically patient is unstable, what happens here is when you allow for permissive hypotension, again your brain is at jeopardy. So maintenance of good blood pressure is important when you also have a traumatic brain injury. So when it comes to pelvic and long bones, remember that fat embolism can also make the brain worse. So we need to try to fix the bones as soon as possible. So let's start with the preoperative stabilization period in a patient with acute brain injury and a polytrauma. So always use a systematic approach of ABCD, airway, breathing, circulation, and a sample assessment to look at what are the injuries involved, and always look for raised ICP signs, which is code brain, altered consciousness level, pupillary changes, or Cushing's triad. In all these cases, a brain imaging is very important. And also look for hypoxia, hypotension, which can be treated immediately, and always assume a cervical spine injury until excluded. And suppose we are not able to exclude a cervical spine injury, then all the anesthesia techniques should include a spine protective strategies and precautions, including a rapid sequence induction. And during at each step in our anesthetic management, we need to take steps to avoid ICP surges. Let's see how we do that. So with regard to the brain, what we do to maintain ICPs within normal levels is the tier approach, where tier 1 is focused on providing adequate analgesia and sedation, maintaining PaCO2 between 35 to 38, and giving intermittent boluses of osmotherapy, and maintaining optimal blood perfusion. And if that fails, then we move on to other ways of trying to protect the brain by increasing blood pressure or adding the sedation much more. If all this fails, then we go in for barbiturate coma. Why am I talking about this is we need to remember that in the perioperative period, the tier therapy might be ongoing in a patient with unstable ICP. So now, how do we decide when to take a patient who has a traumatic brain injury for non-neurological surgery? So it's a multidisciplinary approach where there is anesthetic team, there is a ER team, and the neurosurgeon. All of us have to decide on what is the safe period for the patient for surgery. So first important thing is a clinical assessment. We need to look at the GCS pupillary response and also the imaging stability. There should not be an ongoing bleed or an evolving bleed which jeopardizes the ICP. So this is very, very important when we are considering when to take the patient for surgery. Next is the intracranial parameter. So how is the ICP been? So the ICP has to be less than 20 when we are having invasive way of monitoring. But in our setup, mostly we need to look at non-invasive monitoring of ICP, which can be optic nerve sheath diameter or your transcranial Doppler, and we need to ensure that the ICP is stable. Next is hemodynamic stability, where we look at MAP and SpO2 and hemoglobin. So these three factors are important to prevent secondary brain injury. And the third important thing in all cases of brain injury, always look at the spine, and you need to have an airway plan ready which will not jeopardize the stability of the spine. And then most importantly, the coagulation parameters, because if there is an intracranial bleed, if coagulopathy happens, there is a risk of intracranial bleed becoming worse during the perioperative period. So our clearance for surgery in case of a patient with TBI depends on all these factors. So what are the perioperative goals? So before the patient is taken up for surgery, three things have to be thought about. One is the hemodynamic goals in terms of managing blood pressure targets, ICP, and the vasopressor choice is norepinephrine, and also consider always using multimodal neuromonitoring to ensure brain protection. The second thing is patient should be ideally well resuscitated before patient goes in for surgery, because again, hypotension jeopardizes the brain, and transfusion triggers and practices has to be balanced, where you do 1:1:1 for patients who are going in for extracranial surgery, and also coagulopathy and thromboprophylaxis. So tranexamic acid is indicated if patient presents within 3 hours. This is the crash trial. So that can be given in, especially in cases of polytrauma, and in the advent of viscoelastic testing, definitely TEG and ROTEM can guide our management. So once the patient is stabilized from the primary polytrauma and the brain is stable, and patient goes into the intraoperative period for management, there are few things which we need to consider. So how do we induce these patients? What are the drug choices? So the preferred agent is whatever drug. That anesthesia technique has to be balanced so that there is minimal disturbance to the hemodynamics, and at all times maintaining brain protection as central to it. So etomidate, ketamine is not a contraindication in ICP. If the patient is having hypotension, especially in polytrauma, ketamine can be used if other brain protective strategies can be used, and adequate amount of opioids have to be used. So we need to take precautions to ensure that hypotension doesn't happen. And coming to the use of maintenance of agents, so there is always options between inhalational agent and TIVA. Whenever ICP is not under control and there is a risk of raised ICP, always prefer a TIVA technique, because that will help both in cerebral protection and helping in maintaining good brain relaxation. And when it comes to using muscle relaxation, succinylcholine is not contraindicated. We can use RSI with, provided during your intubation the cervical movement is minimal, especially when you don't know the status of the cervical spine. So this is something very important in the intraoperative period. Now coming to ventilating these patients in the intraoperative period, if the ICP is very high, definitely rescue hyperventilation is indicated. Other than that, try to maintain normocapnia as much as possible, avoid hypoxia, and PEEP can be used up to a level of 15 where it might not reduce ICP. So suppose if you have a thoracic trauma and a bad lung, PEEP is not an absolute contraindication. Now coming on to hemodynamic and CPP goals, maintain blood pressure targets of 100 to 110. Remember the central concept that your cerebral perfusion pressure depends on MAP and ICP. So either you need to institute ICP lowering strategies, or you need to increase the MAP to ensure that CPP is maintained. And hypotension and hypoxia are independent predictors of bad outcomes in patients with TBI. So this is something as anesthesiologists we need to monitor and ensure that adequate brain perfusions are maintained. Now moving to the intraoperative management in terms of fluids. So what fluid should we give? So it is preferable to maintain euvolemia and use isotonic crystallites like plasma light, and avoid hypotonic fluids, and maintain hemoglobin between 7 to 9. And suppose there is risk of lot of bleeding, and this you need to transfuse adequately. And there are few medications which we will continue in the perioperative period. Always remember that seizure prophylaxis with phenytoin or levetiracetam patient might be receiving, so that has to be given in the intraoperative period. And antibiotics, because in case of polytrauma, brain injury, antibiotics will be going, so that has to be given in the intraoperative period also. And according to Brain Trauma Foundation guidelines, there is no role for steroids. So steroids should not be given in cases of traumatic brain injury. Apart from that, in the intraoperative period, positioning of the patient is extremely important, because any head down position or any neck flexion can cause rapid surges in intracranial pressure. So caution should be taken while positioning the patient, and temperature control has to be maintained. Hyperthermia increases the cerebral metabolic rate. So we need to ensure that normal temperature is maintained and blood sugars are maintained within normal range. Thromboprophylaxis is important in terms of you can use stockings or TEDs in the intraoperative period, because there is risk of deep vein thrombosis in these patients, because there can be a procoagulant status. So when we come to looking at the brain when other regions in the body are getting operated, so it's always better to institute a multimodal neuromonitoring. In patients with severe TBI, an ICP monitoring is indicated, but in our setting, if it is not available, non-invasive alternates or can be used like transcranial Doppler. Always remember to assess the pupils before starting the case in the intraoperative period and postoperative period. That's extremely important. Monitoring in terms of oxygenation can be done using NIRS. So remember this, that it's not monitoring one part of the brain. We need to think of how to monitor the intracranial pressure, how to monitor the blood flow, how to monitor oxygen delivery. And also it helps in using a depth of anesthesia monitoring, because it is based on EEG. So in a way, it gives an indirect window to the brain in terms of any seizure activity which happens in the intraoperative period. So it's important to monitor the brain in non-neurological surgeries. So with regard to ICP management in the intraoperative period, like I already said, we need to ensure head position is intact. maintain adequate depth of sedation and good analgesia, and hyperosmolar therapy in terms of mannitol or 3% saline. And if an EVD is present, always you can use that to monitor the intracranial pressure. And suppose if pressures are going up, we can release some CSF through the EVD. And coming to the question of regional anesthesia, there is no absolute contraindication to any technique. Studies have shown that epidural, suppose if the brain pressures are very high, epidural might increase ICP, and also coagulopathy is something we need to consider in the perioperative period before we choose epidural techniques. Spinal, again, it depends upon what is the primary injury and whether the patient is coagulopathic and there is a risk of hematoma expansion. So sometimes in patients with mild traumatic brain injury, regional anesthesia can be given. It is important to assess before and after the functioning of the limb, because there is implications in terms of coagulopathy and damage because of the trauma itself. Once the perioperative period is complete, the extubation strategy has to be clear. For extubation on table, we need to consider the preoperative neurological status of the patient before we decide whether to extubate the patient or continue the ventilation and management in the intensive care unit. And also, it is a good idea to reverse the patient at the end of surgery if ICP is well under control, to look for any neurological worsening. And otherwise, a CT scan has to be done in the postoperative period in patients with moderate and severe traumatic brain injury. Now, when it comes to specific surgeries, abdominal surgeries, increase in intra-abdominal pressure can increase ICP. So you should avoid steep Trendelenburg. Orthopedic surgery, we should avoid induced hypotension. And remember, tourniquet release can increase your EtCO2 and increase ICP. And in maxillofacial surgeries, maintaining airway is very, very important. So these are very specific surgical concern. Quickly, there are 5 conditions where trauma can cross over with extracranial surgery, where the extracranial can be elective or emergency, and the TBI can be mild or severe, or both can be urgent. Example for mild TBI and elective is an orthopedic fixation. Patient concern is patient can have headache or post-consultative symptoms. Remember, cognitive decline or delay can be there. Delayed awakening can be there. So there is a risk of secondary brain injury. So anesthesia technique, any technique is acceptable provided there is good neurological recovery and stable techniques, and peripheral nerve blocks can be done. And evidence is also shown that elective non-neurological procedures are safe more than 2 weeks post mild TBI. In scenario 2, where you have mild TBI and an urgent surgery, for example, an open fracture or peritonitis, here remember that incomplete neurological evaluation can happen due to urgency. So there could be an evolving contusion. So institute a neuromonitoring technique, and also look for hemodynamic instability. Anesthesia technique in this case probably would be a modified RSI, and always maintain normotension map should be and normocapnia, and institute a neuromonitoring technique. Next is your severe TBI with elective surgery. This mostly in the terms of tracheostomy or a delayed fracture fixation. Remember, here ICP is not stable, so there is high risk for secondary insult. So the principle here remains to avoid surgery till ICP stabilizes, and try to institute tire therapy, because here ICP has to be managed aggressively. And neuromonitoring in terms of an ICP monitor or an NIRS or a TCCD is very useful in this setting. The fourth scenario is where TBI is severe. Also, you have an urgent surgery in terms of a splenic rupture. In this case, dual life threats risk are there. So there can be severe shock and coagulopathy. So there has to be simultaneous resuscitation and surgery. So here neuroprotection along with organ protection has to be instituted. And in these cases, blood requirements might be very high. So always keep transfusion ready in these cases. And the last scenario is where you need to operate on the brain and also on an extracranial surgery. Here, there is a need for 2 teams. There has been a demonstration where simultaneous operations have been possible. Here, you need to have 2 teams, one to deal with the brain and one to deal with the other organs. Use of invasive monitoring is very useful, and blood conservation strategies have to be instituted along with neuroprotective management of ICP. So here, time is brain. So early or late surgery at both periods, brain can be at risk. So there are a lot of studies which have shown that outcomes after extracranial surgery depends upon how well the brain is managed during the extracranial surgery. So here is a patient, you can see a contusion. There is also an intra-abdominal collection. So this is an ideal monitor where you have ICP, you are targeting a good CPP, looking at, maintaining normotension. And TCD here shows raised features suggestive of a compromised intracranial flow, raised ICP features, and you can also see the NIRS coming down on the left side. So here head end elevation was instituted, hyperventilation mildly was done, blood pressure augmentation was done. From inhalation it was converted to TIVA and anti-edema measures were instituted, and you can see the TCD flows improving. So this is the importance when both the systems are affected and when you have a good neuromonitoring in place. To conclude, I would like to say that it's important to base timing of the extracranial surgery based on physiological stability. Regional blocks are safe when ICP is normal and coagulation is stable. Always target good brain perfusions and prevent secondary hits, so avoid hypoxia, hypotension, hypercarbia, and hyperthermia. A balanced anesthesia technique is always important. Thank you.
Thank you, Dr. Matanki, for summarizing such a very complex topic. And practitioners and PGs, you will be definitely coming across such scenarios where a head injury patient is posted for femur fixation or a facial-maxillary surgery or intraabdominal surgery. Like she said, the scenarios varies. There might be a severe traumatic brain injury with a severe extracranial surgery which needs immediate intervention, or it may be posted later as a urgent or an elective scenario. In both the scenarios, we need to protect the brain. And she also highlighted the importance of neuromonitoring during such surgeries and how important is that to protect the brain during such surgeries in order to give an overall good functional outcome of the patient. So before we discuss this, I will call upon Dr. Anag for his talk on anesthesia management for patient who has already got a stroke, as well as how to estimate the risk of perioperative stroke and how to prevent the perioperative stroke. We all know there are standard established guidelines for prevention of perioperative adverse cardiac events in a cardiac patient undergoing non-cardiac surgery. And stroke is also a vascular event which can happen perioperatively, and it could be catastrophic at times. And most of the strokes are ischemic stroke, although hemorrhagic strokes and subarachnoid hemorrhage also can happen perioperatively. I would now invite Dr. Anag to go through his presentation, and then we'll have the discussion. Welcome, Anag.
Thank you, sir. I'll be talking about perioperative stroke from the perspective that a patient who has had an old cerebrovascular accident might come for a non-cardiac, non-neurological surgery. So we will discuss the preoperative, intraoperative, and postoperative anesthetic interventions, which will minimize the risk of perioperative stroke. So perioperative stroke is defined as any embolic, thrombotic, or hemorrhagic cerebrovascular event which occurs within can occur intraoperatively, and it is the cutoff period is 30 days after surgery. So it is not just on the day or the day after it. You have to take till 30 days of surgery. So incidence of such events is between 0.1 to 1% in non-cardiac, non-neurological surgeries. Obviously, in cardiac surgeries, the incidence is much higher. So these kind of perioperative strokes can be divided into overt stroke and covert stroke. Overt stroke basically means that there is an acute brain infarct which has a clear-cut clinical manifestation which lasts longer than 24 hours. The point of concern here is there is another entity called as covert stroke, in which the brain infarct is not immediately recognized and patient gets discharged probably, and it is not picked up because it manifests in subtle manifestations, and which are diagnosed later on brain imaging. So they generally come for dementia testing and for cognitive decline many days post-operatively. So there are these two features of perioperative stroke. Also, interestingly, the rate of perioperative stroke seems to be increasing with time, despite decreasing rates of other cause of perioperative mortality. It's possibly because of an aging surgical population with multiple risk factors. So coming to the risk factors per se, It is the predictable ones. It is the advancing age, renal disease, prior history of stroke, and myocardial infarction, atrial fibrillation, hypertension, COPD, female sex. So these are all the independent predictors of a perioperative stroke. Also, high risk of perioperative stroke is seen in emergency surgeries and high risk surgeries. High risk surgeries include thoracic, head and neck, vascular, transplant, and orthopedic surgeries. Interestingly, another risk factor which has been detected recently is the presence of a patent foramen ovale. So apparently it has a twofold increased risk of perioperative stroke. Also, migraine, particularly those who present with aura, they also have a twofold increase of risk of perioperative stroke. So coming to the pathophysiology, so as we know, stroke is divided into ischemic and broadly into ischemic and hemorrhagic stroke. These perioperative strokes in non-cardiac, non-neurosurgery generally manifest as ischemic stroke. Around 95% of them are ischemic stroke and hemorrhagic stroke only up to 5%. So the cause of these strokes is not clear in these non-cardiac, non-vascular surgeries. It is postulated that it is because of hypotension and low flow states which happen due to bleeding or due to anesthesia intraoperatively. Also, patients may have an undisclosed large artery stenosis, may develop anemia perioperatively, thromboembolism, fat embolism, coagulability or thrombosis in this perioperative setting, and also because of mismanagement of antithrombotic medications. Or similarly, mismanagement of antithrombotic medications can cause hemorrhagic stroke also. Another risk factor with hemorrhagic stroke is uncontrolled hypertension perioperatively. So now if such a patient comes to for a surgery, so we will have a discussion with the patient regarding his risk stratification. There are certain tools which are available online for like putting in the patient details, the type of surgery, his other risk factors, and it will give us a predictive score as to how much of a risk does he have. So there is no such tool developed for perioperative stroke which is available, but these scores which were available for cardiac risk can be used for stroke. And all these scoring systems were studied in a large retrospective study, and it was found that the American College of Surgeons surgical risk calculator gave a significantly better predictive accuracy for predicting perioperative stroke. So I urge the listeners to go through this American College of Surgery surgical risk calculator. So when we prognosticate the patient, we can have a frank discussion before the surgery with the patient. So now, since we now have the patient coming for surgery, we will try to formulate strategies which will prevent the perioperative risk of stroke. So one of the important factors here is the timing of surgery after stroke. So suppose a patient comes for surgery, after how long of his stroke should he be operated? So until recently, it was unclear, and it was empirically it was said that around 30 days is fine. But there was a large study in Denmark which found out that the ideal time for operating on a stroke patient in which the mortality and cardiac events were lowest was 9 months after a stroke. It was shown that less than 3 months after a stroke, if the patient is operated, he had a 60-fold higher risk of recurrent stroke in emergency and elective surgery, and 20-fold higher risk in emergency surgery. So having said that, the decision to delay surgery must be carefully considered, and his comorbidities and his primary pathology. Suppose it is a cancer which is invading the nearby tissues, so we cannot delay it for 9 months. So that has to be calculated on a case-to-case basis. Another factor preoperatively when we evaluate these patients is the presence of extracranial carotid artery stenosis. So if a patient has had a stroke, most likely he has had his carotid artery scanned. So if he has a stenosis of more than 70% and has a recent stroke in the last 6 months, it is highly recommended that he undergoes the revascularization procedure of the carotid artery by carotid endarterectomy or carotid artery stenting before undergoing his elective surgery. So similarly, asymptomatic patients with moderate stenosis, symptomatic patients with moderate stenosis can also be considered candidates for revascularization. So in case the procedure is elective and the patient fits the criteria for revascularization, it is recommended that he undergoes the carotid artery revascularization and then gets his elective surgery done. But the optimal duration of this delay is unknown. In asymptomatic patients, we do not recommend routine carotid artery screening. There is a trial underway currently, CREST-2 trial, which is testing whether revascularization is needed at all or not. So whether with medical therapy, the patient is giving good results, or revascularization is required. So that results will give us a good clue for the future. So similarly, now it is intracranial. Suppose there is an intracranial stenosis. Again, there is a possibility that the patient might get to have a stent placed prior to his elective surgery. But again, there is no evidence that supports the prophylactic use of such stenting in a preoperative setting. As we discussed, patent foramen ovale is present in 25% of the population and generally is not associated with any morbidity, but some certain recent evidence suggests that there is a potential association between patent foramen ovale and cryptogenic stroke in patients around 60 years of age, and that the PFO closure can offer some benefit in reducing the stroke risk. Even though these kind of studies are being published, there is a workup bias in these studies that the patients who have got their PFO checked must have had some sort of a symptom and some sort of a concern for cardiac disease, because of which they went for a checkup. So these kind of things muddle up the conclusion. So the final recommendation can be that patients who already need a closure for PFO can undergo the closure before surgery, but urgent surgery or emergency surgery should not be delayed. Now, another preoperative intervention is to optimize his medications. So the patient who has had a previous history of stroke might be having coronary artery disease, might be having hyperlipidemia. So he will be having multiple medications, so amongst which beta blockers is one of them. So traditionally, there was thinking that use of beta blockers in the perioperative settings will be reducing the overall cardiac adverse events. So there was a POISE trial conducted in 2008, which proved that there is instead increased mortality and higher stroke in patients who are treated with preoperative metoprolol compared with placebo. So the hypothesis was that the hypotension caused by metoprolol was the mechanism by which the beta blocker is increasing the stroke. So the guidelines now say that people who are on beta blockers from a long term should continue the beta blockers, but the beta blockers should not be initiated on the day of surgery. So they are associated with higher risk. So another group of drugs is statins. Statins can be continued perioperatively, even though there is no study decrease, like giving a significant stroke protection risk, but other cardiovascular events are protected. So another main aspect of dealing with the medications of these patients is to deal with their antithrombotic therapy. So because of their previous cerebrovascular disease, these patients are often taking many blood thinning medications, which have numerous guidelines. So the challenge basically is that before surgery, you need to make sure that the patient does not get a stroke and have the antithrombotic effect of the medicines. Also, because of the antithrombotic medicine, there will be an increased risk of perioperative bleeding. So how to balance this is the question, and we address it by a stepwise manner. So first is we stratify the risk of that patient for a thromboembolism. So we look for history of atrial fibrillation, prosthetic heart valve, previous history of venous thromboembolism, history of coronary artery disease, stroke, and peripheral arterial disease. So if these things are present, so he'll be considered as a high-risk candidate, and the recommendations will apply as the high-risk recommendations. Next consideration is something called as bridging therapy. So bridging therapy means that we change his anticoagulant to from a long-acting anticoagulant to a short-acting anticoagulant, such that we can continue it till the day of surgery, ideally, and then restart it again after the surgery. So, for example, so the classical bridging therapy is done with warfarin. Patients who are on warfarin, patients who might be having prosthetic heart valves, who will be requiring warfarin therapy to keep their INR at a very high level. So those patients are in a high venous thromboembolism risk. So these patients are advised to discontinue warfarin 5 days prior to an elective surgery. then their INR is checked preoperatively, and when their INR falls below the therapeutic range, low molecular weight heparin at a therapeutic dose is continued till 24 hours before the procedure. So this is called as a bridging therapy. So after the procedure, we can reinstate warfarin, because it will again take around 5 days for the warfarin effect to reach its peak. So warfarin can be restarted immediately, and the low molecular weight heparin can be restarted 2 to 3 days later. So this is the classical bridging therapy. So which is valid for patients who are on warfarin, patients who are on antiplatelet therapy, or directly acting oral anticoagulants. We'll discuss these. So these patients need not be bridged for the surgery. So this bridging therapy, for the students listening, this is a very important concept. Kindly go through these guidelines. So perioperative anticoagulant management. Now, since we have patients who will be coming with one or the other of these antithrombotic medicines, so we can now classify them according to how long you want to hold it prior to an elective operation, and how long after the operation you need to start it. So now again, this will require a little bit of by hearting for the audience here. So I'll just quickly go through it. Unfractionated heparin, or the plain heparin, that is the most like that you can take it till 6 hours before an elective operation. So if the patient is on IV heparin, you can give it till 6 hours prior to an elective operation. So subcutaneous becomes 12 to 24 hours. Low molecular weight heparin, you can give it till 24 hours prior to an operation. Warfarin, as we discussed, has to be stopped 5 days prior, and has to be bridged with low molecular weight heparin. Dabigatran, rivaroxaban, apixaban, edoxaban, these are the ones which are the directly acting oral anticoagulants. So these are the newer drugs. These are the drugs which will be used in the future a lot. So again, I request the audience to go and brush up these pharmacology of these drugs. So dabigatran is directly acting thrombin inhibitor, and its clearance depends on renal function. So it is split into two, the ones which have normal renal function and impaired renal function. So basically, you have to give dabigatran till 2 days prior for a normal renal function, and you have to give it till 4 days prior for an impaired renal function. Rivaroxaban, apixaban, edoxaban can be given till up to 2 days prior for an elective operation. Aspirin, clopidogrel come under the antiplatelet group. So the recommendation is, so again, one point regarding aspirin. So this recommendation is for the bleeding risk and not for the ASRA guidelines, which will determine as to whether you can perform a neuroaxial block or not. So this is not that one. This is the guideline to decrease the perioperative bleeding risk. So according to ASRA guidelines, the prophylactic dose of aspirin, 75 mg aspirin, can be continued till the day of surgery. So this, what we are discussing, is for the management of the bleeding. So aspirin should be held up to 7 days prior, and clopidogrel, prasugrel should be held 5 to 7 days prior to the surgery. So again, this will take a little bit of by hearting for the audience, but I suggest to go through this at leisure, because this will come in your routine practice daily. So now all these were for elective setting. Now, if there is an emergency setting, what should be the management from our side? So patients, so warfarin is a vitamin K antagonist. So if a patient comes for emergency surgery on warfarin, so firstly administer vitamin K and 4-factor PCC. So this 4-factor PCC contains the vitamin K dependent clotting factors 2, 7, 9, 10. So these can be used in an emergency setting in patients with elevated INR secondary to warfarin. So dabigatran has a particular antidote. The other directly acting oral anticoagulants do not have an antidote. Dabigatran has been recently a breakthrough to develop an antidote for dabigatran. So it is called idarucizumab. So that is available. That's very expensive. We have tried to get this. It's very expensive, but we can use that to reverse the dabigatran in patients who are on that drug in emergency setting. Other directly acting oral anticoagulants, you have to give the 4-factor platelet transfusion, 4-factor prothrombin complex transfusion. In antiplatelet agents, so these, again, there is no reversal for these. So it is advised to transfuse 1 unit of pooled SDP prior to the operation and redose if there is ongoing bleeding. So these recommendations optimize the antithrombotic medications such that there is decreased risk of bleeding, and also it prevents the risk of perioperative stroke. So now intraoperatively, we have certain tactics that we can employ so that again we minimize the risk. One is blood pressure management. So blood pressure management basically means that the end organ perfusion of heart, brain, vital organs is maintained. Routinely, what we use is a map of 60 and an SBP of 100 as a thumb rule, that we do not go below these. But these we are normally for healthy normotensive patients who do not have a cerebrovascular disease, who do not have a stenosed carotid artery, those who have such diseased cerebral vasculature might require a little bit higher of a cutoff. So such a cutoff has not yet been published. There's lack of high quality evidence between what actual BP and what is the hypotension. It's mainly because the incidence of stroke is very less, and the studies have to be like the statistically powered to determine that is unlikely. So another reason as to why we are not able to find that hypotension cutoff is that patients get discharged before the 30 days, and we don't know whether that patient had developed a stroke, because the cutoff for a perioperative stroke is 30 days. And so there is another trial which was conducted, POISE-3 trial, which basically in non-cardiac surgeries, they targeted a BP of mean arterial pressure of 60 versus 80. There was no difference in the perioperative stroke rates in either. So again, we are a little bit confused here. So, but we recommend that you do not allow for hypotension. Whatever the baseline BP is, try to maintain the map at the same baseline, not to go too much below the baseline, just to balance it with the perioperative bleeding. Another special consideration is for sitting position, especially for shoulder surgeries. Whenever you are operating in sitting position, there is a gradient which is created between the heart and the brain, perfusion can get decreased if there is hypotension, especially if you are measuring the invasive BP zeroing is being done at a heart level. So it is suggested that if you are using the invasive BP in a sitting position, zero your arterial transducer to the external auditory meatus. And if you're using a non-invasive cup, please calculate that there is a gradient which is there between the cuff and the brain, and it is approximately 0.8 mm of Hg for every 1 centimeter vertical difference between the cuff and the. So for example, if the brain is around 30 centimeters higher than the cuff, so it will come around 24 mm Hg. You have to keep it higher. So if you're targeting 60 map, you need to target 84 map in that case. Another tactic is the use of goal-directed fluid therapy. So goal-directed fluid therapy basically means that you are using certain dynamic indicators to guide your fluid therapy. It can be through an esophageal Doppler, through the arterial waveform monitoring, a cardiac output monitoring. So you generally will be targeting one goal, and you will be giving your fluids to keep your that goal in mind. So this is now being more and more being adopted in all surgeries, even though there is a little bit controversial evidence regarding this. But there has been studies which say that there is an overall reduction of complications. The stroke did not feature in this, and neither did the mortality, but there was decreased renal impairment and decreased ARDS in multiple trials. So this goal-directed fluid therapy is recommended for perioperative stroke prevention. Another point being perioperative blood transfusion management. So again, in these patients who have a cerebrovascular disease, they have exhausted their oxygen extraction capability of their brain. So they do not have the same cerebrovascular reserve that a healthy person might have. So they might have a brain hypoxia at a higher hemoglobin as compared to a healthy person. But instead of having basically, like, even after saying that, the studies, what they have found is those who receive blood transfusions intraoperatively have worse outcomes, have more strokes. Now, so the hypothesis is that the blood transfusions will have associated reactions and infections and transfusion associated lung injury and circulatory overload. And those factors are predominating rather than the oxygen supply to the brain. So the consensus statement is that there is a transfusion threshold of 8 grams per deciliter for most patients, and in high risk patients you target 9. So I would suggest as practitioners we should target a hemoglobin of 9 in patients with neurological illness. Also, these non-infection hazards should be kept in mind, thinking that will improve the hemoglobin, but there is no proven benefit for that. Instead, there is worse outcomes for that. So, but there is 100% this thing that these blood transfusions will cause some sort of transfusion related reactions or injury. So you have to keep both in mind and do it appropriately for each case. Choice of anesthetic technique. Now, anesthesia has been long said that it has neuroprotection. Still, there is no evidence regarding that. Also, on the other side, there is potential neurotoxicity of anesthetic agents. There is no clear evidence regarding that either. So, amongst the anesthetic agents, the one with the most neurotoxic potential is nitrous oxide, which causes endothelial dysfunction. So, it was investigated in the Enigma trial, and it showed that there is no increase in mortality or stroke. So there was another parameter which was investigated was light versus deep anesthesia in the balanced anesthesia study. So this also reported no difference in outcomes or stroke in light versus deep general anesthesia. So the overall summary of this is the choice of anesthetic agent is unlikely to influence the risk of stroke in the perioperative period. So coming to regional anesthesia, again, there was a study around 30 years back in vascular surgery where the patient received epidural analgesia and some patients did not receive epidural analgesia. And there was shown to be like 50% less complications in the group with epidural analgesia. So the entire community got very interested that we can have regional anesthesia as adjunct for each surgery. So in this scenario, these reports or these results have not been replicated in perioperative stroke. Another complication which can develop with regional anesthesia is that the patient might be on the antithrombotic medicines. They might cause the regional anesthesia or neuroaxial blockade might cause sudden autonomic dysfunction or the sudden drop in the blood pressure. So we need to avoid that hypotension. So all those things have to be kept in mind while using regional techniques. Intraoperative neurophysiological monitors. So as neuroanesthesiologists, we have these certain tools such as EEG, cerebral oximetry, and evoked potential monitoring, which can theoretically monitor the brain insult, such as stroke. But these have been validated for use only in carotid endarterectomy, where it can detect the stroke. In other surgeries, it is not yet validated. There is no strong evidence that these monitors prevents the perioperative stroke or any mortality. Another parameter is ventilation strategy. So in that, the most important point being, we should not allow for hyperventilation and hypocapnia. So hypocapnia causes a decrease in the cerebral blood flow, and already there is a insult to the brain or a past insult to the brain, and we do not want that to aggravate because of the hyperventilation and hypocapnia. So please keep normocapnia in these patients. Also, protective lung ventilation is a good practice in any anesthesia ventilation. So it has lower incidence of pulmonary complications, which basically means that there will be less complications of hypoxemia and there is less risk of stroke. So these were the intraoperative things. And now in postoperative period, now we have to make sure that we identify that the patient who has developed a perioperative stroke. So first point being stroke recognition and its challenges. So many of these perioperative strokes are not recognized in the post-anesthesia care units because these patients will be having the residual effects of anesthesia, opioids, and sedation. Some of them might be intubated still, or they might present with non-focal symptoms, again, subtle signs which might get missed, such as agitation, delirium, autonomic instability, and delayed emergence. So in such a situation, we have to have a clear instructions to the PSU staff that you should have some stroke scale in the ICU such that each patient can be neurologically assessed. So the commonly used ones are NIH stroke scale and Cincinnati stroke scale, such that we can pick up the postoperative stroke within the required time. So now suppose a stroke is picked up perioperatively, the institution should have a code stroke. It is like how we announce a code blue in the hospital. There should be a code stroke announcement in the hospital, and which should make the team members of that code stroke run to the wherever the code stroke has been announced from. So there generally will be an anesthesiologist, a neurologist, and a radiologist in the code stroke, apart from the nursing staff. So immediately the code stroke staff should come and do an immediate neurological assessment, send for blood investigations, immediately initiate imaging, and initiate the therapeutic medications and interventions. So first part of the code stroke will be making sure that the patient goes to a plain CT to rule out any hemorrhage. Then from plain CT, ideally.
Dr. Anak, because of lack of time, can we just rush up this topic and
Yeah,
go to
there's
the...
only 2 more slides, sir.
Yeah. Mhm.
So from a plain CT brain, it has to be taken to a CT angiography and MRI to get the parameters. So when the parameters are assessed, the patient can be taken up for endovascular therapy or for mechanical embolectomy. So first one is a large vessel obstruction, which is picked up in a CT angio. Basically means that the proximal part of the one of the brain vessels is blocked, and that is amenable for mechanical embolectomy. Basically, a wire will be passed through and the clot will be pulled out. So this does not require any anticoagulation. Suspected LVO should be immediately taken up for the imaging studies, and if it satisfies the criteria, should be taken up within the first 24 hours of stroke symptoms. So this has an advantage that this does not require any anticoagulation. Some IV alteplase need not be given for this, because in the perioperative period, mechanical, to give a IV alteplase increases the risk of perioperative bleeding. So if the patient is not fit for, if it's not a large vessel obstruction, the patient is a candidate for IV alteplase. Alteplase should be initiated within 4.5 hours of symptom onset, and there should not be any evidence of hemorrhage on CT. The only absolute contraindication is to have a intracranial or intraspinal surgeries in the last 3 months. So these patients can also be taken up in case they are showing the symptoms after 4.5 hours, if they satisfy certain MRI criteria. So which is called as the wake up stroke, that the patient might have woken up from anesthesia with a stroke. So we don't know as to when he developed the stroke. If it was a long surgery, in between the surgery, it might have crossed the 4.5 hours. So these patients can also be taken up for IV alteplase if they satisfy certain MRI criteria, such as the diffusion weighted MRI lesion should be less than 1/3 of the MCA territory, and there should not be any visible signal change on flare. So obviously, if you are instituting these thrombolytic therapies on perioperative cases, there will be a higher mortality rates. And these also you should consider mechanical thrombectomy if it is an option, to take that option instead of thrombolytic therapy. Done, sir. I hope it was insightful for the audience. I'll stop.
So are you touching upon the neuromuscular?
I think we can stop now, sir.
Okay, maybe a few points about the neuromuscular disorders and anesthesia, because it's very important. Certain.
Okay, so we had another talk. Actually, because of lack of time, we'll not be able to do this.
Just few salient points you can tell, so that we can go for discussion.
Neuromuscular disorders is a term with hereditary and acquired diseases. So in that, there is a challenge that we have these patients who have the neuromuscular disorders, which have the respiratory and cardiac complications. A thorough respiratory and cardiac evaluation needs to be done because of the respiratory and cardiac high levels of dysfunction in those patients. So intraoperatively, the patients, the main issues are that we do not use volatile anesthetics in these cases because of their association with malignant hypothermia. We recommend a total IV anesthetic. Apart from that, another important salient feature of this is whether to use neuromuscular blocking agents or not. So amongst that, the universal recommendation is that you do not use succinylcholine. The depolarizing type of muscle relaxant is not used in any of these neuromuscular disorders. Even though in myasthenia gravis, succinylcholine can be used, it is still recommended that you don't use that. So apart from, so succinylcholine, if you give in these cases, precipitates a life-threatening hyperkalemia. So now coming to non-depolarizing agents, these also, if possible, you should avoid. because you can perform a case with only the IV induction agents by their judicious use. So if you want to use non-depolarizing agents, you have to use around 10 to 20% of the recommended dose only. And you have to use a neuromuscular monitor with quantitative train of 4 monitoring to guide your muscle relaxation. So in case you're again using these non-depolarizing agents, use mivacurium or atracurium, because you will not be able to, ideally again, you should not be using anticholinesterases to reverse the neuromuscular agent. So atracurium, cisatracurium have their own spontaneous degradation, or you might want to use the steroidal muscle relaxants such as rocuronium and vecuronium, which can be reversed with Sugammadex. So this is also a boon for us with patients because we have a Sugammadex, we can try for on-table extubation. So in this, another salient feature will be risk of rhabdomyolysis and risk of malignant hypothermia. So this again can be associated with any of the neuromuscular disorders, especially in myotonias. The rhabdomyolysis can be drug induced. Again, scolin can be causing this. So suppose you're giving scolin for intubation. After giving the scolin, the patient becomes rigid and you're not able to use it, not able to use the laryngoscope, the mouth becomes shut. So please avoid scolin in any of the neuromuscular disorders. So this can lead to rhabdomyolysis, the signs of which is metabolic acidosis, hyperkalemia, myoglobinuria, and creatinine kinase very high titers. So the treatment of this involves to stop the potentially causative drug, correction of hyperkalemia, aggressive volume resuscitation, maintain a good urine output, and if hypothermia is present, dantrolene should be considered. So malignant hypothermia, again, now there is some controversy regarding that. So we will leave that and just we'll come to the management. This also basically will manifest like that with tachycardia, sudden increase in temperature, sudden increase in end-tidal carbon dioxide, and you will not be able to, it can happen suddenly intraoperatively or postoperatively. It is related to volatile anesthetic, and management of this is again stop the triggering event, increase your minute ventilation, initiate cooling measures, ensure urine output, treat the arrhythmias, and administer dantrolene at the dose of 2.5 mg per kg until the reaction subsides up to a maximum 10 mg per kg.
All right.
I think that those are the salient points. We will upload a presentation. I think we can.
Sure, Anak. That was a very nice presentation of very complex topic. Now we can stop the screen sharing. We have got some questions as well, and for all the faculties. It's very important that after an acute neurological insult like stroke or traumatic injury, patient can posted for an emergency surgery or an elective surgery. So emergency is emergency. We're going to take up the patients, and so whatever the precautions you said, we are going to maintain it. And if it comes for elective surgery, the common question which is asked is how long should one wait for an elective surgery after an ischemic stroke or after a traumatic brain injury? So this question is for both Anak and for Matanki, because Anak touched upon one important study where it was said that even up to after 18 months, there is an increased risk of stroke if the patient is presenting for elective surgery. And certain guidelines from SNAC and other societies endorsed by ASA, they say that after 1 month, based on the risk stratification, we can take these patients for elective surgery. So over to you. Yeah. So how long to wait?
So the ideal time would be 9 months. Many of the times the practice, we do not have that luxury, but I would say as a compromise, at least 3 months have to be waited for an elective surgery. Ideally to keep it even more because the risk of stroke below 3 months is very high, around 60 times higher than if you wait for 9 months. So
Okay.
my suggestion would be to wait as long as possible if it is not an emergent surgery, if it's something like a knee replacement or something like that. So we can wait for at least 6 months, if not 9 months.
Okay. So like you said, in ischemic heart disease, in cardiac illness, previously it was 6 months, then become 3 months, now 1 month. Now people are advocating you can take it as early as 3 weeks of time after a stent. But Matangi, do you also agree that one has to wait for 6 months, 3 months, such a long period, or we can take up the patient even after 1 month. And also you can throw light upon how to tackle a patient with traumatic brain injury who comes for a elective surgery. So you can take it, you have
Yes,
to
sir.
wait. Yeah.
So with regard to traumatic brain injury, again, brain injury is a spectrum. So each patient has a different thing, but evidence is more than 2 weeks. If the traumatic injury is mild, more than 2 weeks, after 2 weeks, we can take up the patient for surgery. But they have studies have shown that even with mild TBI, if perioperative period is not monitored, worse outcomes in terms of cognitive decline, occurrence of post-operative cognitive decline, which happens even up to 6 months and 1 year after a mild TBI when they are exposed to a second surgery, the occurrence is pretty high. So
All
we
right.
need to ensure the perioperative period is a vulnerable period for the brain. Whether it is 2 weeks, 1 month, 3 months, 6 months, still the injury can occur.
All right. So, to summarize, any patient who's posted for elective surgery after an acute neurological insult should ideally wait as much as possible to get the elective surgery done, because there is a real threat and risk of the patient getting a stroke perioperatively, or cognitive dysfunction, or adverse neurological outcomes post surgery. However, we need to judiciously weigh the risk versus benefit, and we should not be ideally postponing the surgery too long also if it becomes essential, so that we should take up the risk benefit ratio, and we need to provide all the perioperative optimization to prevent a stroke or an adverse neurological outcome. So with this, when a patient is posted for surgery, with respect to ventilation and with respect to hemodynamic management, what are the important things which we need to focus? Of course, ventilation and hemodynamic management is important in all surgeries. But with respect to brain, can you just throw light upon it? Because you're mentioning about hyperventilation, because there are phenomenons like steel phenomenon, impaired autoregulation, which can happen in these patients, and they pose a serious threat to perioperative adverse neurological outcomes. Hypercarbia is as dangerous as hypocarbia as well. And there are certain instances where we have to hyperventilate when we recognize a core brain situation or a raised ICP situation transiently. So for the understanding of the PGs, can you touch upon this, Dr. Matangi and Dr. Sindhu, about intraoperative ventilation in this patient and intraoperative hemodynamic management? Why we stress more to avoid hypotension in these patients? Of course, all the patients we need to avoid hypotension, but in more so in traumatic brain injury, in acute ischemic stroke, why we stress to avoid hypotension, and how to accurately measure the mean arterial pressure, because the mean arterial pressure which we are measuring in the cuff, which is in the hand, may not actually reflect the mean arterial pressure in the brain. Dr. Sindhu and Matagi. Yeah, unmute yourself.
Okay, sir. So in a traumatic brain injury situation or in a stroke, the autoregulation in these patients have been it has taken a hit. So basically, the cerebral perfusion pressure, the cerebral blood flow which goes to the brain, the blood flow which goes to the brain becomes pressure passive. So if you increase the blood pressure, more blood goes, and if there is hypotension, then less blood goes to the brain. So both of which is very harmful to the patient. So that is why we always tell there are two main things that has to be followed during your perioperative period, that is hypotension and hypoxia. These two things has to be avoided at all costs, because these two are two independent predictors of poor mortality for the patients. And we also, so since I told about this, the brain being pressure passive, so we have to maintain a cerebral perfusion pressure of at least 60 to 70 millimeters of mercury, which gets translated to a map of approximately 80 millimeters of mercury. And regarding the hyperventilation, Routine hyperventilation is not recommended according to our Brain Trauma Foundation guidelines, because we are not, in an emergent setting, we are not actually putting a PbTO2 catheter or an SgVO2 catheter to monitor the PaCO2. I mean, we are not monitoring our oxygenation thresholds. So it is only if you have a code brain situation, then only a short temporary period of hyperventilation is warranted, because otherwise, if you hyperventilate, then that is going to cause hypocapnia, which again is going to result in cerebral vasoconstriction. Again, that is going to result in a decreased cerebral blood flow, and again, less blood is going to the brain, and again, that's going to cause more secondary injuries. So, harming the patient more than giving any benefit.
Yes, Dr. Mathang, you want to add anything on
Yeah,
ventilation?
just to add to that, also the ventilatory strategy in the intraoperative period, most of the time we are scared to use PEEP in these patients. But if hypoxia is there, we need always A comes before C and D. So we need to ensure oxygenation is adequate. So using PEEP is not bad in traumatic brain injury. You need to use PEEP to ensure oxygenation is adequate in the intraoperative period. And second thing is, like how Dr. Sindhu had explained about blood pressure targets. There are enough studies to show that even a single episode of hypotension is associated with worse outcomes in traumatic brain injury. So it's important to monitor blood pressure in the intraoperative period, and it's a good idea to place transducer near at the level of ear level, because indirectly it can give us an idea of what the pressure in the brain is. And remember the principle of MAP minus ICP is CPP. So if your ICP is very high, you need to maintain a MAP a little bit on the higher side to ensure CPP is between 60 to 70. So these are the two things which I want to
So
highlight.
on that note, I would also like to stress the importance of, like you said, A comes before B, C comes before D. So in the event of traumatic brain injury, polytrauma with a splenic rupture or a massive hemorrhage, it's always the circulation control which comes before even your brain intervention. Many times people also give mannitol when the patient is hypotensive. When the patient is hypotension, it's resuscitation and hemorrhage control. So that takes the priority. You are also talking about two teams operating together. I think that is not a regular standardized thing which we cannot recommend to everybody. But I think circulation then comes D, because the GCS may be low even if your circulation is not under control. Your cerebral perfusion pressure will be generously low, and once you control the blood pressure and once you maintain the perfusion, your GCS can improve. So this point everybody should remember, it's A, B, C, D, E approach. We cannot jump to D without controlling the C, and we'll be in a disaster. And when it comes to monitoring, intraoperative monitoring, how effectively to monitor the intracranial pressure? Although in most of the situations, intracranial pressure monitoring, the invasive intracranial pressure monitoring will be recommended. It's not regularly, routinely used universally. So how well to monitor the brain intraoperatively when the patient with neurological problem undergoes a non-neurological surgery? In the acute situation, it becomes very, very important. The patient is posted for a fracture femur, intramedullary nailing or fixation. It's a major surgery, and it's also a kind of urgent surgery which has to be done within few days. We cannot wait too long. So in those situations, how well to monitor the brain uh, with respect to brain oxygenation and intracranial pressure, and what are the monitors which are mandatory, and depending on the expertise, what would you recommend?
So an ideal scenario is to have an intracranial pressure monitoring, but which is not practical in a situation of polytrauma where you might have coagulopathy along with it, which comes in the way of putting an invasive intracranial pressure monitoring. So most important thing is you need to remember to monitor the brain in the intraoperative period. Most of the time when a non-neurological procedure is happening, there is a tendency to not look at the brain very closely, but in the acute period setting, you need to look at the brain closely. So what are the options we have in the general setting is we all have an ultrasound machine. So you can look at optic nerve sheet diameter, you can look at your transcranial flows, and NIRS is a good monitor to have a baseline. So any change from baseline with blood loss or there is hypoxia, hypotension, it can trigger steps towards either reducing ICP or improving perfusion. So that is the importance of having some form of monitoring in the intraoperative period for the brain. So coming to depth of anesthesia monitoring, though the evidence is very, very low to use BIS or EEG, but if you are seeing a persistent lower value trend, it should trigger the next response to look at whether brain is at jeopardy. So that's how intraoperative monitoring can be used for patients undergoing non-neurological surgery.
Okay, thank you for that explanation, Madagi. And coming to Dr. Sindhu, there are certain drugs which raises concerns which we use regularly in anesthesia, but when it comes to a neurological patient, we are worried about giving ketamine, we are worrying about giving drugs like metoclopramide, like you said, in Parkinson's disease. And we also worried, like Anak pointed out, worried about giving succinylcholine, be it in a stroke patient or a prolonged neuromuscular illness patient. It becomes an absolute contraindication sometimes because of risk of hyperkalemia. So can you just throw light upon in the management of pain, post-op nausea, vomiting, and anesthetic management? Which are the drugs? Should ketamine be strictly avoided if a patient has got a neurological issue like head injury or stroke, or it can be used? And how about using succinylcholine in cases of traumatic brain injury and acute ischemic stroke? Of course, in neuromuscular disorders, usually it is avoided.
Yes, sir. So, like we have been reiterating again and again, it is A and then B and then it is C. So, securing the airway in traumatic brain injury in an acute situation is the most important. And all emergency situation is all traumatic brain injury comes as a difficult airway, especially when they come with a maxillofacial injury. So always we have to try to secure the airway as soon as possible. So RSI is the way to go about it. And if you're going to give succinylcholine and you're able to put the tube in the patient's airway and secure it, we can give succinylcholine. That is, rather than trying to intubate the patient multiple number of times and raising the ICP, we can just give succinylcholine and put the airway. That would be more helpful for the patient rather than thinking that succinylcholine is going to cause severe excess in ICP. And by literature, succinylcholine just causes 5 millimeters increase in the ICP, whereas you repeatedly trying to do a direct laryngoscopy in such an acute scenario, causing the hypoxia, not securing the airway, is going to do much more harm. And again, regarding ketamine, though ketamine is supposed to increase the cerebral blood flow and increase the cerebral and increase the CMRO2 and increase the ICP, in a setting when there is unstable patient, hemodynamically unstable patient, we can go ahead and give ketamine because, like I mentioned before, hypotension and hypoxia are two things which we have to avoid at all times. So by giving ketamine, we can avoid the hypotension. If you're worried about the raised ICP, then we can give ketofol. 1:1 ratio ketofol can be used and we can intubate the patient. And ketamine has been coming into neuropractice now. It's not like now it's not being used anymore. It's even being used in refractory status epilepticus and so many more indications, especially in children where IONM is being used. We want to get much more good potentials. Also, we're using ketamine infusions. So ketamine is not ketamine. You need to know how to use it and when to use it rather than completely avoiding it.
All right. Thanks for that lucid explanation. Coming to Anag, how about using regional anesthesia in patients with stroke and traumatic brain injury? Most of the times, they are not absolute contraindications, but the neurologists and neurosurgeons, they are worried about giving regional anesthesia for this patient, especially spinal anesthesia. And also, there is a medico-legal fear where people always fear to give spinal anesthesia in a patient who's got a head injury, even though it's a mild head injury, or in a stroke patient. What does the guidelines say, or what is the practice?
So, sir, realistically, for these kind of cases, suppose it is a stroke patient who has one side hemiparesis. It has to be documented beforehand that the patient has a hemiparesis or paraparesis beforehand, before you give the spinal anesthesia. So, in that sense, that the patient might be developing a sudden drop in the blood pressure as soon as you give the spinal, that is another consideration. We have to have the fluids and vasoactive medicines ready when you are giving a spinal anesthetic. most likely it will present with a steep hypotension, and we need to manage that immediately. Again, as we said, that hypotension prevention is one of the main goals in operation of these patients for non-cardiac, non-neurological surgeries. So that being another indication, and the other indication being that these patients will be on some sort of a antithrombotic medicine, might be on warfarin beforehand, might be on these directly acting oral anticoagulants. So there is always that small risk, that nagging doubt in the mind, that if I put a epidural and it develops into a hematoma, it will become a massive, massive problem. So regional anesthesia can be used safely as long as you are making sure of the antithrombotic guidelines, to wait adequate number of days prior to, like, after you stop the medicines, and you have to make sure that these regional anesthesia techniques do not cause a steep hypotension just after giving. So regional anesthesia, again, on a limb which is already paralyzed, whether you want to give or not, that depends on a person to person this thing. If you have documented everything properly, I think you can go ahead and give. If suppose you write, humerus fracture, you can give the block, and it will needs to be documented properly and discussed with the patient everything beforehand. So there is no contraindication for
I
that.
think on an emergency surgery, if the patient is already on any anticoagulants or antiplatelets, it's better to go ahead with the general anesthesia rather than
For
take a
sure.
risk and give
For sure.
a block or anything like that,
For
because the action of the antithrombotics is going to be fully on.
Absolutely.
As well as when an ICP is suspected or the patient's treatment for an ICP, like in traumatic brain injury, it's always in general anesthesia. We
Better
don't
not
go for
to give spinal.
neuroaxial blockade. Yes. So most of the questions from our audience, from our PGs, have been answered, and Dr. Mohan was interested in why, on what basis, 4 to 5 hours is decided for good outcome in stroke endovascular therapy. So that's his question. It's out of purview of this discussion, but anyway, so that is
Based
what
on the
the
trials beforehand,
studies, based on the trials, that those
it was
patients
initially 3
benefit the
hours,
most.
then it
Yeah.
was extended to 4.5 hours.
Yes, right. Okay. So also remember that one important question is, most of the time we don't take consent for post-operative stroke as a risk. Most of the time we take consent, even in high-risk consents, we take consent for post-operative adverse cardiac events. But post-operative stroke is a very rare incidence. And as per the UK guidelines, when an incidence is very less than 1% or so, it may not reflect in the direct consent. But there are some, it can lead to a serious problem also. A major stroke is a serious problem. So even if the incidence is very less and if the problem is going to be serious, we need to take consent. So that practice is not uniform or standard. So can you just, Anak, because you touched upon the stroke, should we take high risk consent for a perioperative stroke?
Again,
And
especially
what are the patients who are at high risk of stroke? Yeah.
that is what. So patients who have a recent history of stroke, like less than, I would say, less than 3 months. Less than 3, you are going even further and saying less than 1 month. Yeah, I would start with that kind of thing. With less than 3 months, I would give them a high risk that you might get a stroke after your surgery or during your surgery. And patients with multiple comorbidities, with carotid artery, if you have imaged beforehand, or an intracranial angio has been done and it shows a significant obstruction, so those patients, I would make sure to counsel them properly.
All right.
Yeah. So basically, another thing what we can use is, I was mentioning that also there are certain tools available which have a perioperative risk calculator. We can start using those kind of tools more.
All right. So there are some MCQs based on the lectures for our postgraduates. You can quickly go through, and somebody can tell me how the PGs are responding. Elective surgeries after recent stroke should ideally be delayed because of what? The risk of postoperative infection is higher, or cerebral auto-regulation remains impaired for months, or general anesthesia is contraindicated, or all surgeries become high risk regardless of the type of stroke. So how to go about with
coming
this?
a bit too enlarged, sir.
Yes, sir, we're not able to see the entire thing.
You need to zoom out, sir, a little.
Is that fine?
This is better, sir.
Better.
Yeah. Okay. So maybe if there's no answer from the PGs faculties, you can.
What is the question?
Elective surgery after recent stroke should be delayed because of what? Because the
Because
cerebral
cerebral vascular
autoregulation
autoregulation is impaired for months.
for months. Okay, so that we have covered in our session. So regarding the ventilatory strategy, hyperventilation consistently protects against cerebral ischemia. Hyperventilation may worsen cerebral ischemia by reducing the cerebral blood flow. Actually, hyperventilation increases the cerebral blood flow. It increases cerebral blood volume and increases the decreases the cerebral blood flow. Carbon dioxide levels do not influence perioperative stroke risk. Hypocapnia is protective against stroke.
Hyperventilation may worsen the cerebral ischemia by reducing the cerebral blood flow.
Okay. So, Dr. Rocky, if the PGs are
Yes, sir.
participating, let me know. Yeah. Okay.
Yes, I'll let you know.
All right. Okay. So, yeah, most of them are choosing the correct answer, I guess. Yeah. So, question number 3. Which
Yes, sir, they are correct
yeah,
answers.
which intraoperative factor is strongly associated with perioperative stroke? Hyperthermia, hypotension related to baseline, use of regional anesthesia, low tidal ventilation. I think, yeah, they understood
Yeah.
the lecture very well, I guess. Most of them
Yes,
are
sir,
answering
yes,
correct.
correct
So,
answer.
hypotension. So, at all
Hypertension.
times, we need to avoid hypotension. It's the single most risk factor for developing perioperative stroke. Not only during the intraoperative period, even during the postoperative period, they have to be monitored in a monitored setup like an ICU or a high dependency unit if the patient is especially at a high risk of surgery, especially the surgeries involving below the diaphragm. There is a colon surgery, the resection, all the oncological surgeries, very high risk for stroke, vascular surgeries. Yeah. So what is recommended when postoperative stroke is suspected? So what do you do immediately when postoperative stroke is suspected? You delay the imaging until the anesthesia effects fully wears off. Immediate non-contrast CT or MRI. Administer aspirin immediately, regardless of giving TPA. Withhold all neurological exams for 12 hours.
Yes. So they're giving the correct answer, sir.
Yeah. So whenever a stroke is suspected, the next immediate thing which we have to do is do a rapid imaging as quickly as possible once the ABC is deemed stable. So without an imaging, you will not know what stroke it is and you will not know what management to give. And like Dr. Anak said, intravenous thrombolysis therapy is the gold standard therapy for treating the stroke, but immediate surgery is a relative contraindication. So if the surgery is in a site where there is a non-compressible bleeding which can happen, then we cannot give IVTPA. And if there is a large vessel occlusion, this patient can go for a mechanical thrombectomy. However, in a case-to-case basis, depending upon when the stroke is happening and depending upon the bleeding risk, even IVTPA can be administered in this patient as it is only a relative contraindication. So succinylcholine, you said, is dangerous in many neuromuscular disorders, mainly because it can cause severe bradycardia, rebound hypertension, life-threatening hyperkalemia, or increased secretions. Yeah, they're choosing the right answer.
Correct answer, sir.
Because, yeah, it can cause life-threatening hyperkalemia, which can lead to immediate cardiac arrest. So it's very dangerous to give in several neuromuscular disorders. Sometimes we may not know that the patient has got a neuromuscular disorder. We may inadvertently give succinylcholine. So you have to be very careful whenever a patient behaves indifferently when you administer succinylcholine. Of course, in most of the elective scenarios, we don't use succinylcholine nowadays, except for emergency cases and very difficult airway scenarios. And this is a point here. Which preoperative test best predicts postoperative ventilation need in myasthenia gravis? It's a very important question because when a patient comes for surgery, a question is asked whether this patient needs a postoperative ventilation. So whether it is an ECG or the serum potassium values or forced vital capacity as assessed by the pulmonary function test or calcium levels. Again, they are choosing the very right answer.
Correct
It's
answer, sir.
forced vital capacity. So deep inspiration followed by deep expiration. So the forced vital capacity, if it is less than 1 liter, those patients will be candidates for postoperative ventilation, because even though they can maintain saturation, they will not be in a position to clear their secretions or maintain their lungs functional residual capacity. So they can go for postoperative pulmonary complications, including lung collapse, retaining secretions, and pneumonia. So patients with neuromuscular disorders are at risk of aspiration because they can develop tachycardia, autonomic instability, bulbar muscle weakness, or improved gastric motility. Yes, so this patient can have bulbar muscle weakness, which puts them at risk for increased aspiration. The primary anesthetic goal in TBA patient undergoing non-brain surgery is to maintain deep anesthesia, prevent secondary brain injury by optimizing cerebral perfusion pressure and ICP, achieve rapid emergence, or use high-dose opioids. So what is the primary anesthetic goal? Yes, the primary anesthetic goal is to prevent secondary brain injury. The primary injury has already happened. The main thing is to prevent secondary brain injury by avoiding physiological insults and maintaining a tight blood pressure and hemodynamic parameters, thereby maintaining cerebral perfusion pressure, controlling the ICP, and providing adequate oxygenation for the brain. Which induction agent is most appropriate in a hemodynamically unstable TBI patient? Propofol, thiopentone, ketamine, midazolam. So, right. So, of these agents which are given as choices, ketamine, although it can increase the intracranial pressure, but in this scenario, when a patient is unstable, it has the least potential to cause profound hypotension. So this can be safely used even in traumatic brain injury, although it can cause a transient increase in intracranial pressure. Remember, ketamine can increase the heart rate, increase the blood pressure, and increase the cardiac output. Thereby, it may be favorable overall, although it increases the intracranial pressure. So ketamine is not an absolute contraindication in traumatic brain injury. So which ventilation strategy is most appropriate during anesthesia for TBI? Hypercapnia, normocapnia, hyperventilation, or zero PEEP? So like we all were discussing, we need to maintain normocapnia because both hypercapnia and hypocapnia are dangerous. All right. Right. So with this, can we close the discussion? If there are any questions, any more questions to answer, we'll answer, or we'll close the discussion.
Thank you, sir. Thank you, entire team, for a very wonderful and extensive presentation of the topic. And I think we must appreciate the, I think they must be postgraduates, Dr. Ummu, Dr. Thangadurai, and Dr. Rashida. Yes? Dr. Rakhi?
Dr. Namita, ma'am.
Dr. Ummu was answering first. Almost all questions, Ummu and Thangadurai. They have answered all the questions correctly. So
yes, ma'am.
They deserve claps. Very good. Well done. 3 questions they have answered correctly. So I think Kaveri Hospital team deserves to applaud them. Okay. And yeah, and one more question is, in the MCQ on the induction of patient with traumatic brain injury, what about etomidate? Etomidate was not put as an option. So can it be used?
Dr. Matangi?
Etomidate can be used, but in a hemodynamically unstable patient, evidence is more for ketamine because etomidate, even one dose can cause adrenocortical suppression, so which might be harmful in the recovery phase in a traumatic brain injury. So the evidence is equal for etomidate and ketamine. It depends upon the patient hemodynamics.
Yeah. And one more question. for Mathangi. In the resource limited setting, if we have a patient of traumatic brain injury coming for non-neurological surgery, say for a emergency laparotomy or something like that, so we will not have the monitoring equipment to monitor the ICP and all those technological advancements. So what would you advise? What should we monitor and what should be our goals?
Okay, so in this setting, assessing the clinical condition of the patient before surgery in terms of neurological status, pupillary size, if there is any features of raised ICP is extremely important. And in the intraoperative period at each stage, like pre-induction, post-intubation, we need to assess pupillary status is minimum to assess in these
Yes.
patients. And if ultrasound is available, then definitely it provides an opportunity to monitor transcranial Doppler and optic nerve sheath diameter. So these are the
Yes.
monitorings which can be used even in a resource limited setting. But it is important to at least remember that brain is at a jeopardy at every point in a non-neurological surgery.
Yes, and we have to keep some hemodynamic goals also, like how much of
Yes.
mean arterial pressure and all. Good. So any other questions from the audience, Dr. Rakhi? Just see if anything is
Ma'am,
left in the chat
Dexmed
box.
and TBA. One of the questions
Uh,
was Dexmed used in TBA.
So there is no contraindication to dexmedetomidine in TBI. It depends on for what do you want to use dexmedetomidine in TBI. Most of the situation, if a patient has mild TBI, patient comes for some other surgery and you want to give a regional anesthesia, the challenge here is patient might not be totally cooperative with regional anesthesia alone, because there can be post-concussion syndrome and there can be a little bit of agitation. So in this situation, dexmedetomidine can be used to kind of tide over the intraoperative period. So that's the role of dexmedetomidine, especially in the intraoperative period when you're using regional anesthesia.
I would
Cut
like
down
to
the
add a
heart
point.
rate though, the
Yes, the
raised ICP.
bradycardia and the
That
hypotension.
you have to keep in mind.
Yes, that we have to keep in mind. And if
Raised
it
ICP
happens,
will also cause bradycardia. The Dexmed will also cause bradycardia.
and
So
the
you're
hypotension caused by dexmedetomidine, again, like we already told that the autoregulation is impaired in these patients. So hypotension again reduces cerebral blood flow, causing again cerebral ischemia. So we have to keep all that in mind. Any medication can be used as long as you know the side effect of the medications and how to tackle it.
absolutely right.
And nowadays in the era of this facial plane blocks and segmental spinal, what would be your advice in a patient with neurological problems? I think the facial plane blocks, again, the problem of bleeding is going to be there.
And
And the
also in
assessment of the
spinal.
motor block is again going to be difficult in a patient with stroke, right? So better
Yes.
not to go with
Ideally
those.
to be
है ना?
avoided, but there is no absolute contraindication for this. If it is documented that the patient has a pre-existing motor weakness, so I think we can, if there are like a contraindication for GA, so we might as well go ahead with a block on the paralyzed arm also if it is required.
Only thing to document it preoperatively, isn't
Yes.
it?
Yes.
What was the degree of block?
Yes.
So I think all the questions are answered. Anybody else from the audience wants to ask any question can raise their hands. So there are no questions. Any questions, Dr. Rakhi, Ishita?
Ma'am, one doubt from my side. When
Chand,
can
from
when
your
can we
side,
give
are most welcome. Yeah.
when can we give spinal anesthesia for a patient? Suppose a patient is coming for a tibia fracture surgery. He had history of CVA. From what time onwards we can give a spinal anesthesia? Like, is there any proper guidelines for it?
Time onwards, like, can you be a little bit specific? The only thing that time wise, what I can tell is the stoppage of your antithrombotic medicines. So the ASRA guidelines deals with that timelines. I think you can go through that, whichever antithrombotic medicine the patient is on, if the adequate time for waiting, adequate time after the surgery and removal of the catheter, it is detailedly given in the ASRA guidelines. So we
Yes.
can follow that. So apart from that, there is no other.
No contraindication. Like there is, until and unless there's no hypertension.
Yeah, you have to make sure that like as soon as you give it in a stroke patient, again, as we discussed, the hypotension you should not be tolerating. So if you are ready with fluids, with vasopressor agents, so you can go ahead with that.
The patient with a stroke, Raki, just to add that, the balance between the sympathetic and parasympathetic is little disturbed also. So I think when you are giving the spinal, I think you have to be little careful. I think titrating a dose is very, very important part, or you evaluate an individual cases, how much strong the stroke was, how much affected the body is. So you can always go like that. There is definitely a, autonomic nervous system is going to play a little bit of a tricky role here. But the duration, I don't think so. Duration will carry, as Dr. Anak rightly said about the antithrombotic agents. That's, I think, only to be taken care of. And also about the dextomid in traumatic brain injury. I think what we people always think over that this drug is a wonder drug. It can be used anywhere. See, you can use it. You can use it for many conditions, but not as a primary drug for something in injury. The neuroanesthesia is a special anesthesia where already the established drug regimes are there. You want to use dexmedetomidine, but there should be some purpose or logic behind it for particular thing, keeping in mind the hemodynamics, keeping in mind the extent of brain injury. So never think that one drug will do a wonder in the traumatic brain injury also. So this is my conclusion on that particular part of use of dexmed in TBI. And I think it's a time for us also to felicitate our faculty today. My screen is visible?
No,
Yes.
sir.
Yeah, so thank you, Dr. Vanamurthy, for being a captain of this ship. Today it sailed very smoothly, nicely, and a long ride. It was a good one and very informative. Somebody must have asked about the recording of the class. Uh, to them, I will just tell them this class will be available when you switch off this class ends. It will be available on the this one YouTube at ISNHQ. The recording will be available there. So thank you, sir, for being the
Thank
captain
you,
of the
sir.
ship.
Thank you so much for this opportunity and thank you, sir.
Dr. Sindhu, you're the opening batsman. So it was a good opening. So thank you very much for that particular lecture of yours, and it was very informative. And I think many of the things all interrelated. And similarly, Dr. Mathangi Krishna Kumar, she was also, I think, and the same platform. I don't think so. You may have partnered or you have discussed before, but everybody was on the same platform, including Dr. Anag also. So it was a very, very, I think, one of the best class I've seen in neuroanesthesia part, if you ask me. And that too, a rare topic, the neurological diseases, the non-neurological surgery. This is a good topic, and it will remain etched in the heart of the ISA NHQ for a long time, and people will be able to listen to this class whenever they have any doubts about it.
Thank
So
you
thank
so
you,
much,
the
sir.
team.
Thank you so much for inviting and asking us to participate in this program. Thank you so much, sir.
All welcome, and thank you
Thank you
very
from
much.
my side also, sir. Thank you to you. Thank you to Panaya, sir.
I
Thank
thank
you.
Madhuri ma'am as well, sir. Thank you, ma'am. Thank you so much. Always
Thank you,
proud to be your
Madhuri
student.
ma'am, Drs. Raki and Ishita.
Raki, we
Thank
also,
you.
Raki, you have to remove your bar A, as I told you. You have to upload
Okay,
your
sir.
registration certificate as well
Okay,
as
sir.
degree certificate to the ISNHQ website, and it will be removed as A, so you will be a life member. Okay.
Thank you, sir.
Thank
Thank
you,
you
sir.
very much, Raki, and your skills I noted today. So you earned some points, brownie points today.
Thank you, sir. Thank you so much, sir.
And Ishita,
Yes, sir.
you were the one who started the class today. Okay, you just passed
Thank
out and you started the class, PG class. I think now you will remain associated with these classes for a long, long time.
Yes,
Thank you,
sure,
Ishita,
sir.
for being the screen coordinators.
Thank you, sir.
And my special thanks to Dr. Madhuri, Dr. Nishant, and Dr. Ridhima because they are always there for these classes for the last 3 years. They have been in the thick and thin of this PG online classes. We changed the curriculum and made it so user friendly that I can only say throughout the country all the PG students who have been presenting the classes here, they become so confident, not just themselves, rather they have invoked a confidence in among all the PG students of the country. Now, anybody can present a class on a national platform. We have a traditional four examiners, two internal, two external, your PG final. But here you get a hordes of external examiner, almost more than 100. And those examiners are asking a question hiding behind a curtain. They will just write in the chat box, this is the thing, how will you do it? So you can very well imagine the volleys of question being faced by the postgraduate students, and sometimes those are of second years and not always third year. The second year answering the things, that means how much the teachers, the students prepare for these classes, the dedication and the commitment to these classes. When you watch this YouTube series of ISNHQ, you will come to know that how much really those people prepared, and they are so much have gained from these classes. And that's why I always thank Dr. Madhuri, Nishant, and Ridhima for being the my class coordinators for the last 3 years. Thank you very much to three of them. So they also deserve a special appreciation. Their appreciation will be handed over to them during the Raipur conference. I have some surprise for you people. Yeah, Dr. Madhuri, you want to add something?
Yes, on behalf of all the screen coordinators, we really thank you for giving us the honor to be the national coordinators for the PG online class. I think every class was unique, and coordinating every class was a different kind of experience. We got to work and we got to know so many faculty, postgraduate students and faculty of different ages and from different locations of our country. So it was an unparalleled experience, and every class has been it's been different coordinating every class. So thank you from the bottom of my heart. And I think all the other screen coordinators would say the same. And thank you very much.
Sir,
Nishant?
may I? Yes, sir. Sir, I'd like to thank you on two counts, sir. First, you considered us to be the class coordinators and given us the opportunity to, to coordinate on such a big forum. The other is, as an honorary secretary, you have been there for all the classes, not one class, I mean, very, very rarely, and not just been present. You have been the one who has taken all the questions. So it is very fortunate for the entire team that such an academic person was there as an honorary secretary. Probably as a secretary, probably this might be the last class, but I'm sure you'll be there for all the classes also in the future. So on these two counts, I would like to thank you. And these classes have very well taken throughout the country. We know that, and hopefully it will continue like this. Thank you so much, sir.
Yeah, sure, Nishant, it will continue like this. It's not just being academician, but this is a passionate. Now I will be having in a new college as a role of a principal. I will be given some guide. I will be a guide to the new PGs who are coming. I think we will soon getting the PGs this after the counseling. As a principal, I have to be on the one side for the college, and other side I have to be taking care of the PG student also. So the classes will never end. They will keep on the this one to YouTube also, as well as to the in the real scenario also. Dr. Ridhima, yourself, our third class coordinator.
Sir, I will use this platform today to express my gratitude to all of you, especially, sir, you. We have learned so many things as a class coordinator also during that dry run, and you were always present throughout the year. I totally agree with Nishant, sir, and you were always watching us silently, and you were always pointing out where we went wrong or right, and it was your mentorship that the classes have changed, and everybody in India will see ki the way you have changed the curriculum of the this classes. It looks like more of a medical college. It seems like we are teaching something. And this is another institute in ISA, that Monday online classes. It's a whole thing. Anybody can revise it. It's a boon to all the PGs. I think we were not that lucky that we have these classes during when we were passing as a postgraduates. And I'm extremely fortunate to learn so much from especially you, Madhuri ma'am, and Nishant sir. So it was a totally, I'm humbled and, just want to express my gratitude.
थोड़ा ज़्यादा हो गया चलो anyway it's okay so the thing is that these classes actually for ISA it's a great privilege to provide these classes free of cost to, because nowadays there are many paid forums are there where classes are being sold. Now, suppose now Dr. Pune, Dr. Sindhu, Dr. Anak, Dr. Mathangi. So these four people on performing on a single class in a one stage, you will not get such type of classes on, even on the commercial platforms also. And they are visible globally now. Every throughout the globe, people can watch this class. I'm just giving example that today's class. See, everybody in the in the world, they will say. Then you go to the YouTube at ISN HQ when you just see this class, many of the concepts will get cleared. And I think we Indians are much better when it comes to the commitment to the academics. And it's always, we may have a little lesser infrastructure, lesser equipment, lesser resources than many of the Western countries, but commitment and passion to the teaching is, I think, highest in India, which I can rate because tomorrow I will be traveling to Raipur. I will be meeting all the WFSA people and Dr. Bala. I will just tell him what really the difference between Indians and other Western people is the commitment and the passion. The passion is very high, especially the teaching passion. The all four of you today took the classes. You prepared it in a short notice and prepared so well that it went so good. And similarly, other classes also went so good, and that is because of the passion only. So I'm really thankful that we people are doing a good job, and in future this good job will continue. And I'm really thankful for today's class to my this one faculty, the coordinators, and all the audience. Because many of the audience I keep on seeing regularly, they are. It's not only me present here. Many of the audience people are also present for a long time. So just we have got 1 or 2 minutes. If anybody want to say something, they can give message before we log off. So I think it's a time, and because I will be packing tomorrow is my flight in the morning because 5 day, 6 day conference of Raipur, and all of you are most welcome to the Raipur. We have got almost 17 workshops and the fledged program of the CME. Then we have conferences. It's a wonderful thing. Dr. Mohan Pathak sir, you want to say something?
Yes, sir. We practice neuroanesthesia for 25 years with minimum facilities like halothane and without central line and pavilion and all these. But we have come along. Now we have got some facilities at least, like evoke potential and other monitors. But initial days there were no facilities like sevoflurane or simple boils machine, and with a hand ventilation we used to practice.
Yeah.
Okay.
Right,
Yeah.
sir. The things have advanced now. Even myself, Dr. Madhuri Riddhima, we are involved in the brainstem death guidelines. We are going with the Government of India, NOTO. We are framing the guidelines, and that is the one thing about the neuroanesthesia. Second part is I am personally involved with framing the guidelines about the BIS and the DSA about and all those neurosurgeries throughout the globe. We are having a big project going on. So Dr. Punay was asking about the guidelines. So that's what I was telling you. Already the base is clear. Tomorrow we are meeting while traveling from the airport to airport. I have a meeting with the NOTO. Dr. Madhuri and Dr. Ridhima will also be there. And thereafter, our first guidelines will be published in the international journal about that BIS guidelines. So those are there. Then it has a base guidelines. Then we will go further from it. So, Dr. Punay,
Yes, sir.
I think I have answered your query last night. You asked about the guideline.
Yes,
ISA may not be feasible because in ISA, there are a lot of different things are there, but we will come out with the our indigenous guidelines also very soon. But these are the to begin with in neuroanesthesia fronts. Your
Sir,
thoughts, sir, before we log off.
I want to say something.
Yeah, please.
Sir, I was younger most year and I felt so overwhelmed by seeing all this, and I'm so happy, and I felt like you gave me this opportunity, and I look up to you guys, and I want to be myself on the other side. I want to see myself. So it was really good experience for me. So
You
really,
have already graduated to the other side. Don't worry.
I mean, like presenting and all.
Yeah.
Like,
Yeah,
Yes, sir.
Punay
So
sir.
you were
Yeah, so that's a very important step in the in the progress of our specialty. I think framing guidelines for our own setup, our own country, and our own fellow colleagues is very important, and we should not decide things which can go sometimes wrong. Even medico legally also, when we frame guidelines and we just guide our practitioners, it becomes very easy for them to practice. So it's a very important and it's a very good step, sir, and appreciation to the entire ISA leadership for coming up with such an initiative. And I think as leaders and as guides, we need to guide the whole nation of the practitioners to practice in a very confident way and also in a protected environment. In that way, the guidelines will have a long way to go.
Yeah, true. I think because last 3 years as a secretary period, I didn't get that much time to be more on the front foot on the academic front of the guidelines framing. But now after this tenure is over, after 5 days, more time will be there. I think that spent will be spent upon the guidelines and all those things. Because at this stage, the policy making is more important, where you can really give the wings to these type of academic endeavors. Otherwise, as an academician, you keep on working hard, working hard. How much we get the credit or how much we really get the things go moving forward. But as a policy maker, as administrator, it's become very easy to give wings to these type of endeavors. I think we will definitely do, and ISA in the next 3 to 5 years, we will be coming out at least minimum. My vision is at least have to have 7 to 8 guidelines on different aspects, coming maybe including all the neuro, obstetric, geriatric, daycare, and we have started the books also, the recent advances in the books. I think that will form the base for these guidelines. Already 5 books are in the pipeline which have started, and more importantly, during this conference, we are going to give a complimentary copy to each delegate and faculty about the research methodology for the postgraduate medical students, which has been edited by Dr. Madhuri and me. So that is a complimentary copy to everyone. The copies have already reached the Raipur. So everybody who's going to come, you can still come. You can get that complimentary copy from College of ISA. So that is the thing. So wonderful. I am really overwhelmed with the class today. A wonderful class. It will remain etched in my memory for a long time. And that too about the last class of my active secretary tenure. So this will be always a memorable moment. So thank you very much to all the faculty members, my class coordinators, and all the audience here. So we will soon meet again on the internet. Again, I think after next 2 weeks, we will have another class. Thank you, everyone. So good night.
Thank you, sir.
And
Good night.
long live ISA.
Long live ISA.
Long live
Good night.
ISA.
Long live ISA.
Thank you,
Long
madam.
Long live
Thank
ISA.
you, sir.